To continue on with our discussion on peptic ulcers, it's interesting to note that in 95% of patients with duodenal ulcers and in 100 patients with gastric ulcers, we have found a bacterial infection from Helicobacter pylori or H. pylori. Now that's after we rule out any alcohol abuse or aspirin usage, like the NSAIDs that we talked about that inhibit the prostaglandin E2 from being made, which is necessary for the protective mucosal barrier. H. pylori is a gram-negative bacterium, and if you look at the picture at the top right, it infects primarily the antrum of the stomach, where we find those G cells in the pyloric glands. And H. pylori causes inflammation of the gastric mucosa. Now, part of the inflammatory cells are mast cells, and they release a lot of histamine. And histamine, remember, is already released by enterochromaffin-like cells. So the extra histamine is actually going to mean now that we get more acid production. And as you saw in the previous slide, it becomes a vicious cycle. So with this constant inflammation, it can easily lead to a bleeding ulcer, shown at the bottom of the right side picture. The H. pylori has a high urease activity, and this allows the bacterium to withstand the very acidic environment of the stomach. And with this comes a high amount of ammonium, or NH4+, and this irritates the epithelial cells, and as I already mentioned, increases acid secretion. We can use several diagnostic tests to confirm H. pylori. One is where a patient drinks C14 urea, and in the stomach this urea is broken down by urease into bicarbonate and NH4 or ammonium. The bicarbonate travels to the lung and is basically expired as CO2, and this is the C14 CO2. And then the person basically breathes into a scintillation drink, and the scintillation cocktail can bind to the C14 found in the carbon dioxide. And then we basically put it into a reader that can detect the radioactivity. Treatment of peptic ulcers can be tricky, especially if it is from H. pylori. If it's H. pylori, we're going to prescribe antibiotics, but it's not quite so simple as prescribing a single antibiotic. To kill off the H. pylori, I have read that it might take 3 different types of antibiotics, plus you have to kind of knock the bacterium back by changing the pH of the stomach, so it's antibiotics along with antacids that can decrease the acidity in the stomach. If we really need to do something advanced, we can actually do a vagotomy, where we remove or sever the vagus innervation of the stomach, or actually remove the antrum of the stomach, the antrectomy as I've listed here, removing the primary pyloric glands that have the G cells. Other drugs that we can prescribe are the hydrogen receptor blockers. We can prescribe the Zantac or Tagamet. And if you look down at my bottom right picture here, you can see that the H2 receptor blockers are going to block the ability to respond to the histamine released by the enterochromaffin-like cells. We also can give proton pump inhibitors, or omeprazole, aka Prilosec, and that is disrupting the hydrogen potassium ATPase, which secretes hydrogen and takes potassium in from the lumen of the stomach. So omeprazole used to be a prescription drug, but it was proven to be so effective that they have now since turned it into an over-the-counter drug. Now we're moving to the small intestine. This is the most important digestive and absorptive organ of your GI tract. There are many secretions and buffers that are provided by the small intestine itself, but also by the pancreas, the liver, through the gallbladder, and I'll talk about all those secretions and buffers. There are 3 subdivisions, starting with the duodenum, which is literally translated as 12 fingers, meaning it's 12 fingers in length, meaning the width of your finger, followed by the jejunum, which is the primary site for digestion and absorption, followed by the ileum. I like to think of this as Down Jones Industrial. It helps me remember the order of them. The ileum is anatomically linked to the ascending colon through the ileocecal sphincter. And when chyme, which is the digestive contents from the stomach, moves through the small intestine and transitions into the large intestine, we no longer call it chyme. It is now officially fecal material. If we look at the anatomy and the histology of the small intestine, we see many modifications that increases the surface area hundreds of fold. First, we see macroscopic folds of the mucosae. These are called plicae or plicae circulares, as some books call them. And I'm showing that up here in the top left picture. Then we have finger-like projections of the cells from the mucosa itself, and this is shown in the middle top picture. And then to the right, bottom right picture, you can see that as well. These are finger-like projections of the actual mucosal layer. Found in the villi, shown in green in the bottom right picture, are lacteals. These are lymphatic capillary beds, blind-ended. Their job is to absorb the fats from your diet and also mix them with the lymphatic fluid. Ultimately, all of these lacteals will form larger lymphatic vessels to lymphatic ducts, like the thoracic duct, which will in turn dump everything back into your official cardiovascular system. Then, if we amplify a single cell from the mucosae, from the finger-like projection, the villi, which is shown here at the very far right, you can see that the individual simple columnar cells in turn have extensions of their cell membrane. These are called microvilli. And in between those tiny little fingers of individual cells, we see a lot of proteins that are kind of hovering there. And this creates what's called the brush border. And this alone increases the surface area many times fold. In fact, it's so important that when some people have celiac disease or are gluten sensitive or have outright immune responses to gluten, this microvilli, this brush border, is lost. And it actually creates a big problem for proper digestion of food and absorption because you're losing surface area. Now let's talk, or let me talk a little bit about intestinal glands. There are a few of them of these, many of them I should say, in the small intestine. Some of them are actual glands that release hormones. We learned about the I cells, the S cells, and the K cells, right? So the S cells release secretin, and secretin will stimulate the pancreas to release bicarbonate-rich mucus, and this will help neutralize the stomach acids. Cholecystokinin is released by hormonal glands in the small intestine. Cholecystokinin is going to stimulate the pancreas to release digestive enzymes, and it also stimulates the gallbladder to release the stored bile. Gastric inhibitory peptide, also known as glucose-dependent insulinotropic peptide, will inhibit the release of gastrin secretion and decreases stomach emptying. So like I said before, it kind of slows things down. But it also has another important role. When the food, or I should say chyme, actually physically touches the small intestine, GIP will also go to the pancreas and stimulate insulin release, even before the food has been completely digested and absorbed. And it turns out this is a dietitian's trick when they teach someone on how to eat properly, and it's not just about portion control, it's not just about food selection, it's also about the order in which you eat your food. And I'll elaborate on that more. We also find duodenal glands, sometimes referred to as Brunner's glands, and they are found within the intestinal crypts. They release bicarbonate-rich mucus, again, to help with neutralizing stomach acids. The small intestine provides its own arsenal of digestive enzymes. This is coming from the simple columnar cells, and these digestive enzymes are the very proteins that I said that hang out with the microvilli and create the brush border. Now there are several enzymes whose job it is to hydrolyze carbohydrates. I do not need you to memorize what maltase does, or lactase, or sucrase. I just merely need you to know that these are enzymes involved in carbohydrate digestion. There are also peptidases. These will break down or hydrolyze the peptide bonds among small peptides and break them down into smaller individual amino acids. There is also an intestinal lipase. It breaks down triglycerides into free fatty acids and monoglycerides. These are the monomers of a triglyceride. These triglycerides and monoglycerides will be absorbed by the lacteals and enter the lymphatic system, in turn to only be dumped right back into the bloodstream. There is also an enzyme called enterokinase, which I have already discussed. It activates enzymes that are released by the pancreas. These enzymes are involved in peptide and protein digestion. They should be only activated when they are in the small intestine and exposed to food. Otherwise, if these enzymes, like trypsinogen in particular, gets activated while in the pancreas to trypsin, the person will develop pancreatitis, and it's extremely painful. The person is quite literally digesting their own pancreas, and the person knows exactly where they are when that pain first hits. It's ingrained in their memory. So enterokinase is going to activate trypsinogen into trypsin, and then in turn trypsin will activate its partners chymotrypsinogen and procarboxypeptidase into active chymotrypsin and carboxypeptidase respectively. Let's focus a little bit more on pancreatic secretion. The pancreas is both an exocrine and endocrine gland. Actually, most of the pancreas, about 98% to 99% of the pancreas, is exocrine in function, which means it's releasing secretions into a lumen that is epithelial lined. So we have several things going on. We have chyme moving into the small intestine, and we need several things to happen. First, we need the acid to be neutralized. This serves several roles in turn. It helps prevent duodenal ulcers, damage to the duodenal mucosa from the stomach acid, but also it must raise the pH of the stomach chyme because the enzymes that are released by the pancreas will not work at such a low pH. And you in fact did a PhysioX that showed optimal pH for different digestive enzymes. Once the enzymes reach their optimal pH, they can then start hydrolyzing the macromolecule nutrients like proteins, fats, and starch, and even nucleic acids down into their monomers. It is only the monomers that can be absorbed. The pancreas plays a vital role in all of these objectives. It releases copious amounts of bicarbonate-rich solution to neutralize the chyme and the digestive enzymes for all the possible macromolecules you ingest. But pancreatic secretion, in turn, needs to be regulated. Of course, it's all about homeostasis. So we have secretin and cholecystokinin that are released from the small intestine, from the cells in the small intestine, whenever food touches the physical epithelium of the duodenum. Cholecystokinin and secretin enter the bloodstream. They are hormones. When they actually reach the receptors in the pancreas, cholecystokinin induces the secretion of the pancreatic juice, the enzyme-rich pancreatic juice. Secretin, of course, causes the release of bicarbonate-rich buffer. We also can see on the right side of the picture that we have the vagus nerve stimulating the pancreas directly. Actually, let me modify that statement. The vagus nerve, with its postganglionic neuron partner, stimulates the pancreas to release digestive enzymes and also the bicarbonate-rich pancreatic juice. So we can get neuronal influence as well as hormonal influence on the pancreas to release its enzymes and bicarbonate-rich juice. As I said, the pancreas is primarily exocrine in function. It's the acinar cells that make and store and release the pancreatic enzymes and bicarbonate-rich secretions. The endocrine function, which I will talk for quite a while in the next few slides, consists of the islets of Langerhans, also known as pancreatic islets. Within these islets, shown here in the bottom right picture, in the little cluster of cells that are colored purple and blue and yellow and red, we have different camps of cells, different types of hormonal cells. There are alpha cells that release glucagon and beta cells that release insulin. But there are many, many more. Delta cells, they release somatostatin. There are even F cells, and I won't go into these. I'm going to focus mostly on the alpha and beta cells. Let's focus on the pancreas as an endocrine gland for just a moment. The beta cells, they release insulin. When is insulin released? When times are aplenty. It's released in your absorptive state, when you've just eaten and you have a whole bunch of carbohydrates that are plentiful and the cells of the body need that glucose. When we talk about insulin-dependent cells, or IDC, insulin-dependent cells, the biggies, the most abundant in your body, are skeletal muscle and adipose tissue. Without insulin, these cells, skeletal muscle and adipose tissue, cannot insert their GLUT4 transporters. So they need the insulin in order to insert these transporters for glucose. It's again called GLUT4. It stands for glucose transporter 4. So you can think of them as receptors for glucose that also can transport it across cellular membranes. So with these GLUT4 transporters, this promotes glucose uptake into the cells. Insulin also prevents fat and glycogen breakdown and inhibits gluconeogenesis. Why does that make sense? Why would you burn through alternative or stored fuels or make new glucose when you've just eaten and you're getting a lot of glucose from your diet? Keep the stores in place. It also increases protein synthesis. Insulin is a lot more than just inserting GLUT4 transporters. Insulin is actually required in order for your cells to absorb amino acids from your diet. And if you can absorb your amino acids, well then this in turn increases protein synthesis within your cells. Insulin also promotes the adipocytes to create more fat storage. Again, you've just eaten. Times are aplenty. It's time to build up the Mormon stockpile, as I like to say. And over here in the right side, we see the epi and norepinephrine inhibit insulin. If you are in a fight or flight response, now is not the time for the cells of the body to use glucose. Save it for the brain. So epi and norepi are antagonistic to insulin. They, of course, help maintain high plasma glucose levels during times of stress and do promote us using alternative fuel like lipids, so these two hormones increase lipase activity. Again, save the glucose for the brain. You're in a fight or flight response. What about glucagon? Glucagon is also antagonistic to insulin. Glucagon is released during your post-absorptive state. That means it's been about 4 hours after your last meal. Glucagon targets the liver and causes the liver to hydrolyze glycogen into individual glucose molecules. This is called glycogenolysis. Glucagon in turn helps us maintain blood glucose levels in between meals, like I said, post-absorptive phase, and during times of fasting. The nervous tissue, the brain, is not insulin dependent. We say non-insulin dependent cells, or NIDC. This is because brain cells, neurons, have a different glucose transporter. It is a glucose transporter that is embedded in the cell membrane all the time, unlike GLUT4, which has to be inserted when and only if insulin is released. Because the brain uses different glucose transporters that are there all the time, it has access to glucose from the bloodstream indefinitely. So the brain tissue is going to be heavily dependent on blood glucose levels. If you are in between meals, your brain cells could starve. So we need to then shift to saving glucose only for the brain cells, and in between meals you start to burn through alternative fuels like proteins and fats. Again, the liver is going to start with glycogenolysis to release glucose for the sake of the brain cells. The glucagon also stimulates transport of certain amino acids to the liver, and these amino acids can be in turn turned into brand new glucose that you haven't eaten. This is called gluconeogenesis. Gluco for glucose, neo means new, and genesis means new synthesis of. Let's briefly start to talk about diabetes mellitus. There are different types. We used to say type 1 diabetes used to be called juvenile onset or insulin dependent. We can no longer use those descriptors anymore because even elderly people can get type 1 diabetes, and even people who have type 2 diabetes might need insulin. So now we just say type 1 diabetes. It does usually develop in persons before age 15, and it can develop very, very suddenly. And with diabetes, we say that there are 3 pathies and 3 polys. The 3 polys mean the person does it too much. There's polyphagia, which means the person is eating too much. Polydipsia, which means they're drinking too much because they're dehydrated. We learned this already from our body fluid compartments lecture. And they have polyuria, which means they're going to the bathroom a lot, and especially during the middle of the night. If you're talking about little kids that are actually developing this, the number one thing that drives the parent to bring the kid to the doctor is actually the parent is annoyed because the kid is constantly up in the night, going to the bathroom, calling for water, drinking a lot of water, then going to the bathroom again, and the parent is just outright irritated because they're losing sleep. Number one reason why the child is diagnosed with type 1 diabetes. I find that phenomenal. With type 1, it is pancreatic failure with respect to the beta cells. This means insulin-dependent cells, like skeletal tissue and adipose cells, have to use alternative fuels. But you learn from your metabolism level or lecture, when they use alternative fuels like fats and proteins, those 2 alternative fuels still get shuttled into the mitochondrial matrix for the Krebs cycle. They are burned down to acetyl-CoA. And this is a problem because the first thing that acetyl-CoA does is bind to a 4-carbon molecule called oxaloacetate in order to form citric acid. The problem is oxaloacetate is carbohydrate derived. So if you have cells that are now carbohydrate deprived, they're going to use the oxaloacetate in order to make glucose. This means burning alternative fuels can't go to completion, and now the acetyl-CoA will be shunted into alternative metabolic pathways, and this leads to ketoacidosis with ketone body formation. We learned about this in our metabolism lecture: beta-hydroxybutyrate, acetoacetic acid, and acetone. Of those, acetone is volatile and escapes through the breath, which is why the person with diabetes mellitus has sweet breath. The other 2 are true fixed acids. We call them keto acids. The only way out of the body is through the urine. So we get the beta-hydroxybutyrate and acetoacetic acid out in the urine, hence the ketoacidosis. The acidosis is a problem in the bloodstream. Now the patient's pH is dipping below 7.35, and they can go into a diabetic coma. That's what I mean by CNS depression. It really means that the insulin-dependent cells are truly starving in the face of plenty. There's a lot of glucose in the bloodstream to be had. They can't even burn their alternative fuels properly. The cells are starving. And this means it can lead to a diabetic coma, where you get central nervous system depression from the acidosis. The person who is taking insulin to control this can accidentally overinject. They don't purposely want to overinject, it's just that they might have misgauged how much food they ate, and now they've injected more insulin than the food that they have eaten. Now this leads to insulin independent, or IC cells, insulin independent cells, to be without a fuel source. We're talking about the neuronal cells. And this too can lead to a hypoglycemic coma. They're still slipping into a coma. Another kind of diabetes that I have listed up here is gestational diabetes. Gestational diabetes is considered not to be type 1 nor type 2, just an other kind of diabetes mellitus. In this case, the pregnancy hormones are impairing the mother's ability to respond to insulin. She might actually be releasing insulin in appropriate numbers, but her insulin-dependent cells are not responding like they should. I had gestational diabetes with my youngest son, Mac. The interesting thing with this, or actually kind of a sad thing about this, is both Mac and I have a 40 to 60% chance of developing full-blown diabetes later in life, usually within 10 to 15 years of birthing the child. 40% chance for us to, 60% chance for us to develop type 2 diabetes, which I will talk about in the next slide, and a 40% chance, even if we keep the weight off, of developing type 1 diabetes. With gestational diabetes, we do not mess around with a pregnant woman. If she cannot get her blood glucose levels under control, her fetus will absorb copious amounts of glucose and become very large in utero, big baby. And this means the head and shoulders are no longer going to be the widest part of the baby the woman has to birth. It'll be the thoracic region. And this means the baby can actually get stuck in the birth canal or cervical canal. It is considered to be a high-risk pregnancy, and they will not mess around with this. They do several things for the pregnant woman. First, she is identified during her normal glucose screening as having an abnormal result. Then they'll send her back to do a glucose test, a bigger one, where she drinks this really awful orange, very sugary drink, has to drink it within like 10 minutes, and it's so nasty you want to throw it up. And then they draw blood before she drinks it. They draw blood within, I want to say, 15 minutes after she drinks it to see her peak levels. And then they'll draw her blood every half hour for the next something like 2 hours to see how her body reacts to that high sugar load. If that test comes back that she has not managed the glucose appropriately, then they're going to do several things. First, they're going to send her to a dietitian. This is where she will learn how to manage her carbohydrate proportions and when to eat her carbohydrates. This is what I learned from the dietitian when I went. I had to learn that a carbohydrate portion was about 15 grams, and we are supposed to eat 4 to 6 servings of carbohydrates, but the trick is throughout the day. Now, just to give you a visual, a single serving of a carbohydrate with respect to a piece of bread would be you taking that piece of bread and cutting off 1/3 of the bread, and the remaining 2/3 is considered a serving. I have a question for you. How do you make a sandwich? I don't see any of you cutting off 1/3 of a slice of bread and then cutting the remaining 2/3 in half and then making your sandwich. If you're making a traditional sandwich with 2 slices of bread, you are essentially getting three servings of a carb all at once. And that's not counting all the other stuff you put on your sandwich. So that was an eye-opener for me. I was told that I needed to eat carbs, but I was also told that there was a time of day when I should eat them and when I shouldn't. I was told to really watch my carb levels when I first woke up in the morning, and that really makes sense. What hormones are ragingly high in the morning? What haven't you been doing at night? You haven't been eating. You've been sleeping. So your glucagon levels are high, and your epinephrine levels are high, and your cortisol, and if you think about growth hormone, that's released in the night too. And all of those are diabetogenic, right? They cause increase in blood glucose levels. So I was told, absolutely not, no cereal, absolutely not, no cereal. And not even just in the morning, but throughout the day. Too much sugar. Too many carbs in one serving. Plus, no milk. Milk has a high glycemic index. I was told to drink milk, but not in the morning. Save it for later in the day with my lunch or dinner. I was also told the order in which to eat my meals. I was told to eat my proteins, like cheeses, and fats, like maybe from meats, first. Save the carb last. Genius. Because if you go back and you look at one of the earlier cells where I was telling you about the G cells and I cells and S cells and K cells, you should have realized that these cells released their hormones from the physical contact of food. So if I ate my proteins and fats first, then I would have GIP, glucose-dependent insulinotropic peptide, released. And before I even ate my carb, that GIP would target my pancreas. My pancreas would release insulin. Before I even ate the carb, my body would be primed and ready. And then when I ate my serving of carbs, my insulin-dependent cells, or IDM, or IDC I should say, insulin-dependent cells, were primed with their GLUT4 transporters. I thought that was genius. To this day, I try very hard to stick with this type of diet. I was told by my dietitian that this wasn't just a diet for diabetics. This was how we were all supposed to eat. Scatter our carbs throughout the day. We should eat every 2 hours. Small little snacks in between your big meals. Breakfast, don't have a big meal. Save your big meal for either lunch or dinner. My breakfast, one that I learned would not spike my glucose levels high in the morning, would keep them at the level they were supposed to be, to this day is one of my go-tos. I find it very satisfying. I would have a singular one corn tortilla with cheese and 2 sausage links. Microwave that, and I was good to go. And I felt very satisfied. 2 hours later, I would have a few crackers, and by a few I mean 4, depending on the cracker type. 4 crackers are typically a serving of carbs, and then some cheese with it. That would tide me off for 2 more hours, and then I would have my lunchtime. It was actually a very good diet, and unlike the other pregnant women on the street, I did not gain a huge amount of weight, and within 2 weeks after Mac being born, I was back into my regular clothes. And all the previously pregnant women on my street were highly jealous of that. So again, to this day, both Mac and I try and adhere to that diet, very mindful that we are potentially ticking time bombs, and the stats are not in our favor. 40 to 60% of us developing some type of diabetes mellitus, those are not odds in our favor. When we come back for our next segment, I'll talk about type 2 diabetes.